we can finish. So welcome to the Asia Pacific Ocular Imaging Society Symposium. Today our theme is the future of ocular imaging, and obviously everybody is doing AI now, so we're going to touch on technologies, imaging and AI. And without further ado, I'd like to introduce our first speaker, very well known, Professor Ki-Ho Park, who will be talking about glaucoma imaging. So, Professor.
Thank you, Marcus. Could you open the first presentation?
So your good name?
My name is Ki-Ho Park. Yeah, the last one.
The last one.
Right. Yes, okay. Thank you. I'm Ki-Ho Park from Seoul National University. My talk is about glaucoma imaging hardware. So these are my disclosures. So I'm going to talk about the hardware in AI and hardware in telemedicine, and also hardware to image retinal ganglion cell itself. So this is the first telescope invented by Galileo, and technology evolves very fast. So we can get higher and higher quality and higher resolution image. Similarly, in fundoscope, now we are using direct ophthalmoscope, indirect, and also slit lamp fundus examination. About the fundus camera, the prototype was like this, and we have nice cameras, and also we have a small handheld or cell phone-based fundus camera as well. So using those fundus images, we can apply AI in those images. So super resolution generative adversarial network was employed to understand the disparity between low resolution optic disc photograph and the manually compensated high resolution photograph. So using this AI, we can get 4 times higher resolution of optic disc photograph, and those enhanced photograph can detect disc hemorrhage more accurately. OCT has evolved very fast as well. So we have spectral domain OCT and swept source OCT as well. So using those OCT images, the AI can be applied to diagnose early glaucoma. So for distinguishing between patient with early stage glaucoma and normal subject, dual input using RNFL and GCIPL OCT images, the CNN's diagnostic ability was higher than the algorithm that trained with RNFL or GCIPL separately. This work was done by Toru Nakazawa's Japan group. They also found that the machine learning system can accurately differentiate between healthy and glaucomatous subject based on the combination of the extracted images from OCT and color fundus images. So it was better than each separate OCT images. This is an OCT angiography. The advantage of OCT angiography is that it does not require contrast medium or dye. However, the limitation is difficulty in quantification and lack of normative database. To overcome this limitation, AI can be applied. So OCTA superficial capillary plexus and deep capillary plexus, and also OCT GCL plus, which means GCIPL in serous OCT, and GCL2 plus, which means GCIPL plus RNFL. So those images were used to apply deep learning. And as you can see in the heat map of the OCT angiography, that the highlighted area by heat map was the region with decreased vessel density. And also in OCT, the highlighted region was the area with decreased thickness. And deep learning model with macular OCT angiography, superficial capillary plexus images demonstrated excellent and comparable diagnostic ability to that with macular OCT images in highly myopic glaucoma. So myopic glaucoma diagnosis can be comparably done by OCT angiography. This is the telemedicine in glaucoma. For screening, we can use those cameras and tonometers, and AI can be applied to it as well. In the public area like subway station, we can put those OCT instruments or tonometers in future, and it can be applied to AI as well. For the monitoring glaucoma, remote center primary physician or some primary center, they equipped with the fundus camera and OCTs and tonometers can be used as well. In future at home, home tonometer or home OCT or head mount display visual field test can be used at home, and also it can be applied to AI as well. For the future imaging, direct visualization of the ganglion cell can be possible. It is in mice model, and if the adaptive optics can be applied to OCT or SLO, like in telescope, we can see directly the ganglion cells. So it was published in 2017 in human eye, imaging the retinal ganglion cell itself. The retinal ganglion cell layers, cells can be seen by adaptive OCT or the adaptive optic OCT. In summary, due to advancement in imaging devices, the AI can be applied to these images to screen for and diagnose glaucoma. Lower cost imaging devices suitable for home or public use will bring the future of telemedicine closer, and we can directly visualize the retinal ganglion cells as well. Thank you for your attention.
I have a question. Anyone has questions? I have a question. So, I'm just interested to see, I mean, congratulations on all the work that you've done. How many images or how much data do you need to train a reliable AI? And how much validation is required for glaucoma? Because I'm coming from a place where I do some AI in cornea and in myopia as well.
Very good
and
question.
the validation is difficult. So it's good on my population.
Yeah, very good question. In our glaucoma study, as many images as possible, but usually for our study purpose, we are using hundreds up to more than 1,000 to get well training, and also we need to validate with different group of the samples. So that will make the accuracy more better.
And in fact, in Asian population, for example, in myopic eyes, the optic nerve head is often distorted, and so the application of the AI thus or interpretation becomes more challenging.
Yeah, it's very good question as well. The myopia is a very big issue in Asia and also in the world. So in our region, normal tension glaucoma is the prevalence is very high, and also in younger generation, myopic increase will make myopic normal tension glaucoma, the prevalence is very high. So in those cases, how to diagnose myopic glaucoma more accurately, that AI may help, and also, like as I showed you that instead of optic nerve, there are too much variation in the myopic eyes. So a little more accuracy is around the macular area. So AI also can be applied to OCT thickness images and OCT angiography images, and also around the optic nerve, retinal nerve fiber layer thickness. Sometimes it varies. So minimum rim width or peripapillary peripapillary RNFL thickness can be applied to AI as well.
Rupesh?
Hi, thanks, Dr. Park. Always a pleasure to hear to you. So as we know, particularly for glaucoma, glaucoma is defined by optic nerve head changes, intraocular pressure, and visual field changes. Now, the imaging in glaucoma, the AI in glaucoma is largely based on optic nerve head images, where you have not taken into consideration the visual field and the intraocular pressure. So for me, let's say you screen a person with abnormal optic nerve image for a patient. How do an AI can tell this is a glaucoma, because it might be coming to me looking at an abnormal disc, but otherwise everything is normal. So for me, the future of the glaucoma AI should be looking into something which we don't know.
Right.
Some changes which AI can pick up, which our human eye cannot pick up, and if it is able to pick up those changes, which are very sensitive on a validated cohort of glaucoma, which has been missed and not able to pick up by the human, and that can make a difference. Otherwise, what will happen is there will be a false referral of a lot of glaucoma patients to clinic. What are your thoughts? Are you people looking into something which OCT, which a human eye cannot pick up? Can AI look beyond what we can know?
Yeah, very good point. We do not exactly know what AI is looking for to diagnose glaucoma. So I did not introduce in my slide, but a few years ago, we applied an adversarial example which tells that where the AI is looking for to diagnose glaucoma. And what we found was that they are looking at the neuroretinal rim, and also they are looking at the peripapillary atrophy, and also they are looking at the retinal nerve fiber layer defect. So that's what we are doing to diagnose glaucoma. So that can give us some clues.
The explainable AI may be the future for some of those things. Thanks.
Thank you.
Thank you. I think some of these answers we'll get from after the next talk. So I would now request Dr. Masahiro Miura would be talking to us on glaucoma imaging AI.
Yes, thank you. So please start my slide here. Yeah. Start my slide, myself. What should I do?
Can you put the slides?
Oh yeah, here. So my topic is glaucoma imaging and AI. This is my COI. So why is AI necessary for glaucoma? One reason is the number of the glaucoma patients is expected to rise from 76 million year 2020 to 111 million by year 2040. Among large number of glaucoma cases, an estimated 63% of patients are missed. Why? One reason is a high patient volume needs to be managed and difficulty accessing ophthalmologists in remote areas. One possible solution is an AI-based low-cost and compact testing device and test general clinics with AI-based telemedicine. Another reason is that glaucoma is a complex disease. One possible solution is AI-enhanced precision and objectivity for ophthalmologists. Now I want to explain about the low-cost and compact testing device and AI. One good example is a smartphone-based anterior segment images, PSLD20 and celestron systems. Using these devices, deep line-based automatic anterior chamber depth estimation is reported. It's very good for the diagnosis of the angle closure glaucoma. Other good examples of gonioscopy, iCam, and smartphone-based gonioscopy, DIGS Pro. Using these devices, deep line-based automatic anterior chamber classification was reported. It is very important for the diagnosis of glaucoma. Another approach was smartphone-based color fundus photographs, FOP NM10 and VISTAS. Using this device, deep line-based automatic detection of glaucoma with optics image was reported. Another good example is a tablet-based visual field test, Melbourne rapid field, and low-cost compact tonometers, iCare Home. Using these low-cost and compact design testing, multiple tests at general clinic could be possible, and data were transferred to the medical data were transferred to the AI server, and AI server suggests the general clinic about the regular checkup, prescription eye drops, or referral to the ophthalmologist. One good example of this system is a Moore Field Diagnostic Hub. That is a doctorless medical examination facilities in public space and shopping malls. And data were transferred to the Redfund Moorfield Eye Hospital multimodal automatic diagnosis system and suggest one transfer the diagnostic hub such as prescription eye drop or refer to the ophthalmologist. So as a short summary, AI enables evaluation of glaucoma-related parameters outside the ophthalmology clinic, and glaucoma diagnosis become possible, even in general clinic using AI-based telemedicine. Next, I want to explain the AI-enhanced precision and objectivities. Why is necessary? Glaucoma diagnosis can be challenging, even for glaucoma specialists. One reason is an automated glaucoma test shows variability between measurement. Good example is the Goldman apprenation IOP measurement. Another problem is the interpretation of test result demand scales. For the automatic IOP measurement, deep line-based automatic Goldman apprenation tonometry was reported. It improves the accuracy of IOP measurement. And for the interpretation of test result demand scale, to overcome this limitation, for example, anterior segment photograph, discrimination of the failed and functional brave using deep learning was reported. It improves the post-glaucoma surgery management. For the color fundus photographs, low-quality image is an essential problem for AI diagnosis. To overcome this limitation, deep line-based detection of high-quality image to increase the accuracy of the automatic glaucoma diagnosis was reported. Another good example is anterior segment OCT. Deep line-based automatic quantification of the anterior segment structure was reported. It improves the AI-based evaluation of glaucoma. And also deep line-based automatic gonioscopy was reported. It quantifies angular structures. For the retinal OCT, segmentation error is an essential problem in OCT-based glaucoma diagnosis. To overcome this limitation, deep line-based automatic detection of segmentation errors were reported and improves the accuracy of OCT-based glaucoma evaluations. And also deep line-based approach was used to improve the accuracy of segmentation, and the deep line-based segmentation-free approach was also reported. And it improves the retinal fiber layer thickness measurement without segmentation errors. For the visual field test, deep line-based automatic detection of glaucoma progression was reported. It contributes to the treatment plan, and automatic detection of glaucoma progressions using unsupervised machine learning was reported, and the deep line-based automatic detection of early glaucoma was reported. It improves the accuracy of the early glaucoma diagnosis. As glaucoma is a very complex disease, multimodal AI approach is very important. One good example is the OCT and visual field test. Using this multimodal AI can improve diagnosis accuracy bringing it closer to that of human doctors. And since a multimodal approach was also reported, this is a good example. OCT angiography was used to estimate visual field abnormalities. It provides a synthesized multimodal approaches. So as a short summary, glaucoma diagnosis can be challenging even for glaucoma specialists. And AI has a potential to provide valuable support in both diagnosis and treating glaucoma. Last part is a challenge of AI in glaucoma. One challenge is a large variation of definition of glaucoma, even in the large scale studies. Sometimes complexity rates of 0.7 or 0.8 or 0.9. Unified standard for diagnosis of glaucoma is required. And another problem is a bias by small sample size. To overcome this limitation, federated learning, decentralized database, and GAN was reported. And another problem is deep learning is a black box natures. So possible solution is explanation by heat map or large language models. As a conclusion, significant progress in glaucoma diagnosis and treatment is expected through the use of AI and low-cost testing devices. Thank you.
Any questions from anybody who want to ask? I think great talk, and that did give us an idea how AI, yeah, please.
Yeah, I just wanted to understand the foundational models, red found and all, how are they performing in terms of as compared to the old deep learning models? Are foundational models the new way for analyzing various eye diseases?
What?
Repeat again.
My question is, you mentioned in the slide red found,
Oh, yes, found. Yeah.
red found,
Yeah.
which is a foundational model,
Yes, yes.
which is a new wave, I would think.
Yeah.
Do they perform better than the traditional deep learning models?
So to answer this question, so we need more experience for the deep learning diagnosis. We don't have a real answer right now.
Is there any commercially available AI system that system that can be used for all this by other centers also, where the possibility of coding for the artificial intelligence is not there?
Repeat again.
Is
Is
there any
there-
commercially available AI system
Commercially available.
that can be integrated with the various types of machinery? Because not everybody has the ability to collaborate with the artificial intelligence coders and all these people. So like, and also the machinery differs everywhere.
I'm not sure about the glaucoma or the AMD. So some AI-based OCT automatic diagnosis system was reported. It probably equipped to the commercial system soon, but I'm not sure about the glaucoma.
Okay. There is no further question. Thank you so
Thank
much.
you.
We will move on to the third talk. Dr. Xin-Yuan Zhang, she will submit pre-recorded lecture. So her topic is retinal imaging and for diagnosis. Could you run the pre-recorded third lecture?
Good morning, chairs and everyone. It's my great honor and pleasure to
Video is not
join
coming.
the APOIS Symposium. As a retina specialist and AI enthusiast, I'm going to share with you our recent findings about AI-assisted predictors of systemic diseases using Finder's images. This is our financial disclosure. We don't have any financial interest on this project. And here is the outline of the presentation. As we all know, retinal vein occlusion is the second most common retinal vascular disease, causing vision loss after diabetic retinopathy. VRVO was described by Leber in 1977, and CRVO was named by von Michael in 1978. RVO is the fifth leading cause of adult blindness. With the advancement of a finer imaging system, the diagnosis classification is not difficult for clinicians. However, the pathogenesis of RVO remains unclear. Recently, the correlation between RVO and systemic diseases have been attracted interesting. Several studies have confirmed that RVO significantly increases the risk of ischemic and hemorrhagic stroke. These findings indicating closer anatomical and physiological relationship between the two. I'm showing a meta-analysis which provides the evidence that there is a strong correlation between RVO and all-cause mortality, stroke, and myocardial infarction. Some studies also provide interesting results. This study indicates the correlation between resting state functional MRI imaging and clinical features and symptoms of RVO related to vision loss and anxiety, which may further result in changes in the activity of the brain. This study provides the evidence that the association between the abnormal synchronous neural activity and RVO. These two studies also found a correlation between RVO and open-angle glaucoma. Because BRVO and primary open-angle glaucoma share the common risk factors such as fluctuant intraocular pressure and optic nerve damage, the incidence of POAG is higher in RVO patients, especially among those with elevated intraocular pressure. However, previous studies have not differentiated between BRVO and CRVO in terms of their correlation with POAG. The research has only focused on the relationship between RVO and POAG in general. Therefore, more detailed study designs are needed to distinguish which type of RVO is more closely associated with systemic diseases or POAG. While there's no evidence linking RVO with systemic disease and open-angle glaucoma, as we previously mentioned before, previous data did not differentiate between CRVO and BRVO in terms of their correlation with relationship. To answer the three clinical questions, this study aims to investigate if there is a disparity in the correlations between BRVO and CRVO with systemic disorders or POAG, and further to explore the pathogenic difference between BRVO and CRVO. We designed a nested case control study. The study group included 59 unilateral RVO subjects, and the control group involved contralateral healthy eyes. And this is the inclusion and exclusion criteria. We collected baseline information, conducted detailed eye examination, developed the AI-based imaging analyzer for quantitative measurement of the relative retinal vessel caliber, further measurement of cerebrospinal blood vessels geometric parameters. We apply the Beijing ICOP study method, which uses the orbital cerebrospinal fluid space in glaucoma to indirectly assess the association between intracranial space and normal tension glaucoma. This study indicates the lower orbital CSF pressure is observed in patients with normal tension glaucoma. The scheme to demonstrated the optic nerve shells complex. Figure B shows a schematic drawing of the optic nerve shells complex, including the optic nerve surrounding cerebrospinal fluid space and optic nerve shells. The flowchart which indicates how we developed the AI-based image analysis. Briefly, we use the deep learning segmentation network ResNet 101 UNet and deep learning object detection network SSD for identification, segmentation, localization, blood vessels and optic nerve, and then perform quantification. These two photos demonstrate how the AI-based image analyzer quantified retinal vessel geometric parameters, including the first angle at the vascular bifurcation and the relative arterial to venule diameter ratio. The green circle represents the radius of these circles is 0.5 dd, 1 dd, and 1.5 dd at the center of the optic disc respectively. The relative anterior or venular diameter was calculated at the mean value of the diameter of the anterior or venular to the average diameter of the optic nerve. These photos show how we measure the cerebrospinal blood vessel geometric parameters based on MRI images. Regarding the baseline characteristics of the subjects, the results show a statistically significant difference in hypertension duration and intraocular pressure between the BRVO and CRVO patients. We found that the proportion of BRVO patients over 45 years of age is significantly higher than that of CRVO patients. Additionally, BRVO patients have a higher incidence of hypertension, but a significantly lower relative abundance of intraocular pressure, higher than 21 milliliters of mercury. This table shows the retinal vessel geometric characteristics in BRVO appear to be more closely correlated with brain vessel-related parameters, while CRVO seems to have a stronger relationship with retinal vessel geometry. Furthermore, brain-related parameters in the contralateral normal eyes show significant differences between BRVO and CRVO. Additionally, both brain and ocular parameters in the affected eyes differ significantly between BRVO and CRVO. We also found that optic nerve subacranoid spaces at 3 micrometer behind the globe of the CRVO affected and contralateral normal eyes group was significantly higher or wider than that of the BRVO affected eyes. The multivariable logistic regression analysis showed that ONSASW at 3 micrometer and wider relative retinal venular caliber were risk factors for CRVO compared to BRVO. This is a typical case whose left eye was diagnosed of BRVO with macular edema. Sniffer and lower density vessels in the left cerebrospinal vasculature suggest a potential link between BRVO and cerebrospinal vascular damage. The lack of significant difference in optic nerve subarachnoid space between the affected eye and the contralateral eye further suggests that BRVO is more likely linked to cerebrovascular events, with no strong association to primary open-angle glaucoma. In summary, we found that the pathological mechanisms of BRVO and CRVO is different. Cerebrovascular characteristics indicate a strong link between BRVO and cerebrovascular diseases. The optic nerve subarachnoid space difference between BRVO and CRVO suggests a potential association between CRVO and POAG. BRVO and CRVO require distinct management strategies with potential to their risk factors and complications. So in conclusion, BRVO is more likely related to cerebrovascular diseases, where CRVO may be associated with POAG. BRVO and CRVO actually represent different pathological types requiring distinct treatment strategies in clinical practice. Imaging differences in the geometric features of retinal and cerebrovascular vessels may expand the pathological distinctions between CRVO and CRVO. So challenges, take-home messages are very closely associated with both systemic and ocular local diseases. The retina is serving as a window of predicting and monitoring cystic conditions. Further biological imaging biomarkers based on AI analyzer remain to be explored. So this is the our collaborators and team members. Thank you so much.
So because this was a pre-recorded lecture, we won't be able to ask her questions, but we can discuss this more when Rajiv is presenting later. So I'd like to invite the next speaker then, Professor Rupesh Agrawal from Singapore. We'll be talking about uveitis imaging.
Thank you, Chess and APOIS for giving the opportunity to present. So a disclaimer, this is not the AI talk as against the previous, as like the previous speakers. I'm just presenting on imaging in uveitis, and then leave it to the future AI leaders to see, including Rajiv and all, how we can integrate AI into uveitis thing. So no particular conflict of interest as far as this talk is concerned, and just want to highlight the role of imaging in patient with uveitis. So we do have at our disposal quite a lot of imaging devices, and we want to see how do we use this multimodal imaging in uveitis for the patient management and all. So I will be touching upon some of the images which we use and how it helps us in our practice. So the first and the foremost, and this was one of my first posters when I was at Shankar Netralaya under training with Dr. Biswas, and he used to say, why don't you do montage photography? And I was saying, what is this montage photography? And he was always fancy of that in 1999, and this is before the wide angle imaging was introduced. So he asked me to present a poster at TNOA meeting, and that was my first ever paper or poster presentation on montage fundus photography in uveitis. So here I am after 25 years of that, still presenting on imaging and particularly about the montage photography in uveitis. So the current state of art is the use of this imaging and how does it help us as a doctor in managing the patient. So I have divided the color fundus photography into certain learning points which we can help understand more better that this is just not photography for the sake of doing it. How does it help us? So it does give you some insight into the disease through the true color and three-dimensional depth. So not that even with this brightly lit room, you can still appreciate that there is something happening in this fundus picture, but we want to see what are the other things which can we evaluate while we try and understand between the true color and the pseudo color. So this is a gentleman who presented to us with the swelling on the retina looks like, and then we have taken this picture. So you can appreciate that both eyes there is some elevation which is seen, and this was done on November 17, 2022 on the Clarus fundus photograph, and the patient also had the OCT scan. You can appreciate what you were seeing on the fundus photo also is seen on the OCT. So first and foremost, that you need to appreciate that there is some fluid there on the fundus photograph, and therefore I brought up those pictures. Eventually the patient underwent steroid treatment, aggressive, and then the patient has the resolution of the fluid. So this is again, if you don't have disposal of the OCT, but at least on the fundus photograph you are able to appreciate the three-dimensionality, the elevation, which sometimes can be a bit difficult to appreciate otherwise. The second important point, and a beautiful work done by Anirudh Agarwal and Vishali Gupta on this thing, is the differentiation between the different types of color fundus photography. And sometimes you should see in your clinic itself, you have different types of cameras, and how many of the cameras actually pick up those lesions. So sometimes you will be surprised that some of the cameras actually can miss certain key findings. So this is again, how does multicolor imaging or the pseudo imaging missed some of the lesions which was actually there on the retina but was not picked up just because of lack of true color. So once again, a call to a lot of manufacturing devices company, if they are there, to come up with the device which will not be able to miss some of the lesions, because otherwise it can be misleading, and particularly when we are talking about the telemedicine and everything, and if such a picture come to us, we'll be missing it. So I've seen that many times happening. So the point number 2, tracking lesions with precision. And how do you do that? So you can monitor the progression of the lesion. So this is where you can see a patient with a serpiginous choroiditis with a particular lesion like this thing, and this is which is defined again. But once this patient comes for follow-up, using the color fundus photograph, which might not be applicable for your naked eye because you might not be able to differentiate, but once you do, you can pick up that the lesions are progressing, and you can very nicely delineate from one visit to second visit. And sometimes we have started the treatment just based on the fundus photograph, because it is impossible for you to differentiate a single little spike coming on the serpiginous choroiditis. So it can be a good device for you to monitor, and also at the same time tell to the patient, this is why I am increasing your steroid or decreasing your steroids or stopping your steroid or changing something else. About the wide field, beyond boundaries, so something, a term which I like it. I thought again, this is a very dear friend whom I treated for last 1 year for acute retinal necrosis. I saw on a social program in Jaipur last year on 29 February when I was attending a common friend's wedding, and then she happened to be presenting with this next day at some racist clinic in Jaipur, and we went there, and then we saw this particular lesion which was there. But this is afterwards. So this is 28th March when the patient was back in Singapore. But before that, Rajiv and SN faculty were involved in treatment of her. But you can see, if you don't do, what are the things which we can miss? If you don't do a wide field, you can see just the hemorrhages, but once you do that, and how does it matches with your visual field also. So you can see with the treatment, we were able to monitor, and with the photograph we were able to monitor the progression of the lesions and how we were able to track the lesions. So therefore it is critical that the photographs are taken in this patient to monitor the progression or the resolution of the lesion, and also at the same time. So this is again the montage photograph also on the Clarus, because sometimes even the wide field of the Clarus can miss, or you can go for wide field. Different companies are there, even Optos, and there are more wide field imaging company. But for particularly for uveitis context, it is extremely critical that we do as many pictures as wide field, because sometimes there are some lesions which are sitting in the periphery. Once again, it can be helpful for evaluating or guiding your treatment intervention. So this was one of the patient again, not that bad, and you were trying to kind of evaluate the extension and progression of the retinal hemorrhages. And with this photograph, we were able to kind of identify whether there is still lesions there, and that helped us in the treatment. Again, this is a slide shared by Dr. Vishali Gupta, and you can see how this patients was again help with the use of the color fundus photography, which was. This is again one of the extensive patients which allow us to use imaging to tell us whether to continue and with the same treatment or being a bit more aggressive. You can see the peripheral patches of retinal necrosis, and that has helped us in understanding it. And that's where call to the AI community to help us, not just the diagnosis, but also in helping the progression and the prognostication about using this lesion. But there is so much of heterogeneity. It's really what Chair Marcus commented about the number of images which we require. Therefore, we are not able to come up with really good tools for the AI for this thing. Last, which I like to present before I end my talk about, so I'm just keeping it on the fundus photograph, because sometimes we don't talk too many things about the fundus photograph. We'll leave OCT, OCTA, FFA, ICG, quite a number of things which you can use it in uveitis. But last, sometimes there are very subtle signals. So you can sometimes miss on your fundus evaluation if you're not very careful, but sometimes you see. And then I go back to the patient again, hey, did I miss something when I see the photograph? Then you go back again, and then you see, oh, actually there was a lesion, but somehow you missed it on the slit lamp or on your fundus photograph. So this was again some of the certain small things which sometimes can be missed. Not in this patient I missed, but there are, I'm sure all of us miss, and sometimes I do miss as well. And then I say, oh, okay, this is something which I missed, and then probably it could have been picked up, and it helps you to identify whether you are dealing with a uveitis or something, some other soft things there. So what are the benefits which we have seen now? It is to evaluate the disease extension, probably with the diagnosis as well, the disease progression, early detection of complication, characterization of the disease, differentiating from each other. We are working on a project to differentiate infective versus non-infective just based on the fundus imaging. Hopefully we will come out with something, but right now we are not there anywhere. Evaluate the severity of the disease, evaluate the disease resolution, evaluate the progression of the disease in the periphery. So these are some of my key take-home points for you to use your fundus cameras for managing your patient with uveitis. With that, I'd like to thank chairs for giving the presentation. Thank you.
Thanks very much for the really nice presentations. Rupesh, I was wondering, of course, like you said, back in the 90s or early 2000s, we were actually montaging the photos together. But now in the commercial space, as you know, there are several companies with wide field fundus imaging, and in fact most of them now also combine it with OCT and OCT angiography wide field. So are you finding that useful in your uveitis practice, or do you have any preferences on how you practice now? Did it change?
Yeah, so this is a very good question, and I completely agree. So there are two thoughts to it. In my practice, which is an academic center, where we are at a disposal to a lot of wide field imaging devices. So once in a while, I go back, so I run a CMV retinitis clinic on Wednesday morning and Friday afternoon, and we do fundus photograph for all of them. So sometimes when I see a patient and I see on the fundus evaluation that there is a CMV retinitis lesion, I ask the photographer in the next room to take a wide field photograph. And I don't tell that I'm looking at this lesion. I just give them can you check it? And I just do it randomly. Then they come back to me with the photograph. You will be surprised, between those wedges of the two overlapping picture, the CMV retinitis is missed. So you just miss it, even though it's a very nicely done by one of the most experienced ophthalmic technician with the 7 field, and it just missed. I said, there was this lesion. Oh, Dr. Rupesh, sorry, I missed it, and she felt guilty. I said, you don't have to feel guilty. I'm just trying to understand how did you miss it, and you are such an experienced photographer. So there are still scope for direct evaluation that some of this montage photography can miss in an academic practice. But the main important thing is that a lot of people in the private practice or in small practice and in a smaller institution, they might not have exposure because the devices are a bit expensive. So still there is a role for direct clinical evaluation as far as uveitis is concerned. You can't rely only on the 45-degree or the standard photography which I get.
And a quick mention again about the combo imaging. So you've showed a lot of nice vasculitis and also fallout and hemorrhage and all that. So a lot of the systems now incorporate like some OCT angiography as well. Do you find that useful? And especially in the periphery where
yeah, very useful. So I could not show that pictures, some of those things. It's extremely useful, and we try to use it, and we are doing it for one of the project of retinal vasculitis within one.
Yeah, you can ask that.
Rupesh, can I ask you a small question?
Yeah.
Has SERP source made any difference in your practice?
A lot.
That's why you didn't emphasize much on that.
Yeah, I did not emphasize, but
because
I think
that probably is going to be the game changer.
Yes.
Understanding diseases much deeper and much into different planes, it makes your understanding of the disease in particular very, very good.
Yeah, it's a lot, and thanks for bringing up that point, but thank you.
Rupesh, I have two questions. One is that what you feel are the markers on imaging to suggest active inflammation? Because that's the most confusing thing. You start on treatment and at some stage you are always worried whether still inflammation is active or it is. So what you suggest would be some of them which are very, very crucial.
Yeah, so very good question. So IUSG, International Uveitis Study Group, has set up a committee called as MUV, Multimodal Imaging in Uveitis. We are trying to look into that, and one of the things under that was looking at the disease activity and markers. So right now the consensus is any presence of vitritis, means if you are talking about the OCT, so based on imaging can be different things. So based on OCT imaging is vitritis, which can be picked up as the cells, or presence of subretinal fluid or macular edema. These are the two important things which has come up as a marker of disease activity, at least as far as that. But if you talk about the fundus photograph, the lesions, the color of the lesions, the ages of the lesions have come up as an important marker for disease activity.
That's what I was.
Yeah, so on the fundus photograph, the color of the lesion, if the lesions are granular, if the lesions have fluffy edges, irregular edges, can suggest us on that. So it again is based on which imaging.
The second question is again going little beyond your wide field only photography to angiogram. One of the major problem which all even retina people face is PVLs.
Yes?
PVL, perivascular leakage, which is a
PVL,
pretty
yeah.
normal phenomena in the periphery. Especially in a case of uveitis, that becomes a real problem whether you are dealing with some inflammatory leakage or it is a normal PVL. That becomes a, so what you feel, how?
So very difficult question. So with Jim Rosenbaum and group Mark Desmet and Vishali, we have set up a group called as Revise, which will be the big thing to come up. And one of the key question is that retinal vasculitis versus retinal vasculopathy, because sometimes it is the sick vessels which just leaks the blood, the leakage, but there is no vasculitis, versus a retinal vasculitis where there is an active inflammation leaking it. So I think we should watch out for some of the publications which will come out from this group, but just to give you a glimpse into that, Invernizzi has done wonderful work. He has done some OCT imaging through those blood vessels and able to show inflammation within the retinal blood vessels and thickening of the blood vessel, which will be able to differentiate BRVO or some of the CRVO from that, but he is not able to differentiate diabetic retinopathy versus the retinal vasculitis. But again, a very, very important thing, and that will help us whether the patient should continue to get immunosuppressive treatment, steroid treatment versus no. Thank you.
Thank you so much. Our next speaker is Dr. Rajiv Raman, who will be talking about retinal imaging AI.
Thanks, and thanks APOIS for hosting this very nice session on imaging, complementing with AI. So next few slides I will be talking about AI trends in retinal imaging, what are the newer frontiers. So now we have better performance matrices to measure the performance of AI. We have every day getting new case use. Even last few presentations we have seen new uses of AI, and definitely when the AI work started there was a lot of human intervention as far as training is concerned that has significantly reduced. I'll just go through some of these algorithms, how they evolved with time, and some examples in retinal imaging. So machine learning algorithms are not new, and I think this was one of our work which we did in 2003-04 with IIT Chennai, where we were keen to look at can we detect diabetic retinopathy using machine learning algorithm, automated ones, and this was simple support vector machines, random forests were used, and we used a public data set, showed a reasonable good sensitivity, specificity, but when we used it on the patient, it was less, didn't suffice to be used in clinical practice. And then came the deep learning techniques. They can automatically learn features from a raw data. The need for manual feature extraction went away, and there are CNNs, which are these examples in diabetic retinopathy, and this was the work we did with Google. Happy to share that in 2021 it was judged as one of the top article of the decade. So deep learning algorithms became very popular. Then came many of the other algorithms which are called as ensemble methods. People started combining multiple models to achieve a better accuracy, better robustness. And this was one of the study which we did. We collated all the population-based studies which are done in India on diabetic retinopathy and tried creating an algorithm which can detect retinopathy without images, probably a risk factor based, and give the whom you should triage to take a retinal image, and this was ensemble method. So we used the classic machine learning techniques, we used the deep learning techniques, and then made an algorithm. Then came another concept called as transfer learning, which utilizes a pre-trained model of a large data set. So again, your computational resources became less, and that's what was done on diabetic retinopathy. People started training on a general image data set like ImageNet, and then fine-tuned it to retinal images. And this was one of the work which we used this transfer learning to find out whether image is gradable or not gradable, because if it's non-gradable, it can give a prompt to the photographer to take a retinal photograph again. Then came hybrid methods. Now hybrid methods is not ensemble. Hybrid methods are where you integrate the different techniques into a cohesive system and which can directly find out the features. And this was one of the work which we had done, that retinal biomarkers of inflammation from SDOCT, probably using them in diabetic macular edema to find out whether it's more inflammatory component or more angiogenic component. So here we use the hybrid method. So the purpose of this talk is to tell some work which has been done and what techniques have been evolved with time in AI for retinal images. One of the things which has been a drawback of many of these methods are that these are black box, people don't really know. And then came the role of explainable AI, and now it is a FDA requirement that any of these algorithms should tell what it looks at to find out, to find or detect a disease. And there are many of these algorithms which can find out what it looked at. There are about 13 of these algorithms which we tried looking at, that which is the best method for giving the explainability in a deep learning algorithm for ophthalmic diagnosis. And we found the deep Taylor method as one of the best way to find out the explainability. There are many segmentation models which can delineate anatomical structure, and this has again jumped a long way as far as OCT imaging is concerned. We can now detect or segment various fluid areas, volumes, and there are now FDA approved devices, Retina AI, Discovery AI. These are the ones which can actually give more quantitative matrices from a OCT cube scan. And these are again something which has been because of these segmentation models. And this was a work which we did with Zeiss, where we tried looking at all these fluid pockets and quantifying these volumes. And we heard this term in last talk also. Now we have federated learning, where you don't really need to share data. That's a major problem in many institutes. You can have a decentralized data, multiple institutes, and the model resides in the cloud. So that's one method which really picked up, and that has made a lot of progress as far as retinal imaging AI is concerned. One of the example where we were part was a deep ultra wide field, a federated model which was led by Professor Carol Cheng from Hong Kong. More and more now, generative adversarial networks are playing an important role, because we understood know that there are certain diseases which are rare. You don't have so much of data set, and these are the networks which can generate images. It can augment the data set, and now we have much better the diffusion models where you can augment. You want a specific age, you want specific severity of the disease which is less, you want to add more. So these have really played an important role, and this is one of the work where people have tried from retinal fundus photography generating fluorescein angiograms using these GANs. One of the questions which was asked before was on foundation model. Definitely they are one step beyond, because these are pre-trained on extensive diverse data sets, multimodal data sets, and Professor Pierce Keen's work, the first foundation model. We have another foundation model from China, but definitely there is a need for a much larger foundation model based on ophthalmic images. One of the work which was led by Professor Tin Wong, where we were fortunate enough to be part of it, was a deep DR plus system which integrated multiple of these techniques, used deep learning, transfer learning, ensemble, predictive modeling, and on a multi-ethnic data set which could predict the time of progression of diabetic retinopathy. And I can just show the Indian results, that is from our SN-REAMS data set. The average recommended screening interval, which routinely is 1 year, we could extend it to nearly 32 months. And that reduced the frequency of screening by nearly 62%, with a only 0.37% rate of delayed detection. So that is something which is possible because of integrating many of these systems. Now the next level is the large language models, and now these integrated image-based system have been combined with large language model. Just to conclude, we have better performance matrices, as I had told, we have new cases, and there is less need for human intervention. I'd like to thank my research team for doing these work. I'd like to invite all of you for the APOIS Retina meeting on trauma in July. Thank you very much. Any questions?
Thank you. Questions, please.
First of all, Rajiv, congratulations for
Good
your
morning.
for your JAMA paper, which I had a couple of dinner meeting with Howard Bochner, and the editor-in-chief of JAMA. Every time he praises your paper, he said it's the best. That's the best paper he ever read, and which he edited as an editor. So I think Rajiv, great. And as far as the federated learning is concerned, I'm quite interested in that thing. But do you think the model which is developed on a particular system, let's say on a Zeiss or on a Topcon or any particular system, and it goes to another one which has a different sets of images and all, how it is going to work, that model which you develop, and let's say you give it to another state in India or across India to somewhere, or someone developed it in US or Singapore or Hong Kong. Have you actually tested that? Has the model been working? Because I believe that will be the real challenge of federated learning, how the model developed.
I would say federated learning would be opportunity, because you give it on various systems. You are looking at only weights of training, what you have got from various systems. Based on that, at least you can say that when your overall performance may reduce, but when you get various data set, you can train. So you can use that. So federated would be actually opportunity, and that's how, if you look at the ultra wide field work of Professor Carol Cheung, she has actually looked into multiple devices, spectra, like even the OCT work which she has done is on multiple devices, and she could do it because she used the federated.
Yeah, yeah, but yeah, she went to a particular center in Thailand and they did. So we are trying to do something for uveitis where we have tried and we done with the data and we are trying to do with the images.
Great.
And because uveitis is small data, and then we,
Yes.
I think federated is something which will be helpful for us. But I
Absolutely.
think whatever medical retina, if you learn something, please allow uveitis people to learn from you so that we can take it forward.
Yeah,
you know, because
definitely.
we all rely on you. Thank you.
I have a question. As you showed, the AI can detect angiography from fundus photograph.
Yeah.
So it is very amazing. And AI can detect foveal avascular zone, new vessel, and also leakage.
Yes. So there's one recent work which I'm presenting in the next session where we tried using the ultra wide field images, and we use the ground truth from the ultra wide field and use the posterior pole image to train it. That's what Rupesh was telling. There are signals which probably we don't see. So the findings of peripheral retina could be seen on the posterior retina, highly accurate.
Thank you.
Thank you very much. So I think we'll play the next recorded is Professor Lin Hao Tian, who is talking about temporal prediction in slit lamp. Can we play the next pre-recorded lecture?
Good morning, dear friends and fellows. I'm Lin Hao Tian from Dongshan Academic Center. I will talk about technological development and implementation of artificial intelligence for collaborative management of cataracts. There is no conflict of interest in this presentation. Before my sharing, I'd like to introduce our hospital briefly. Dongshan Ophthalmic Center is the leading eye hospital in China, serving over 1.4 million outpatient visits annually. We now serve as the WHO Collaborating Center for Eye Care and Vision and host the headquarters of the Asia APO. On the occasion of our 16th anniversary, we are excited to host the International Ophthalmology Hospital Presidents Summit. We welcome you to reunite in Guangzhou for this precious ophthalmic assembly and immerse yourself the charm of South China. Cataract is an example of common eye disease, leading to around 14% of blindness worldwide. Over 80% of the elderly population suffer from cataracts, which are highly associated with multiple systemic disease. Therefore, early screening and treatment is quite crucial. However, the traditional medical patterns faces a serious challenges, including growing medical demands as well as limited quality resources. So we expect digital technology might be the breakthrough to address the problems, enhancing the efficiency and medical equality. As the initial step towards cataract management, we set foot in the AI screening diagnosis of cataracts with different types. You may think the diagnosis is simple for an ophthalmologist compared to retinopathy. That's true, but it remains challenging for AI development, especially applied into clinical practice. On one hand, for the image features, cataract pictures from slit lamps can be in different capture models for different etiology patients and in different stages of disease. On the other, for the application scenarios, we are not making use of the primary health care facilities or patients themselves. The referral system needs to be improved as well. To solve these problems, JLC has established a global collaborative platform which we call Home for Pediatric Cataracts since 2011. The national level platform paves the way for the subsequent data sharing and standardization for the disease. On this basis, our team went ahead and tried the application of AI to promote the congenital cataract diagnosis. Considering quite a few ophthalmologists are experienced in diagnosis for rare eye disease, we explored a deep learning-based image classification system for congenital cataracts named CC Crucial. The image features including lens capacity, opacity regarding the locations and density were considered to provide reflow suggestion. As for the age-related cataracts, we extended the modalities of the image utilized to train the general cataract AI agent. The results show that for the model determined diagnosis of normal lens, cataract, and postoperative eye with an AOC of more than 98% in all captured models. It could also provide reliable reflow advice with AOC over 19% in all cases. To further provide its diagnostic efficacy in a real-world setting, we have conducted the first RCT study to compare the AI system with ophthalmologists in cataract diagnosis. We are inspired by the result that the AI doctor achieved comparable diagnostic accuracy with ophthalmologists, but superior to human beings for time saving and satisfaction rates. In terms of cataract treatment, surgery is also the only effective way at present, and there remain some challenges for cataract surgery. It is a long journey for a junior fellow to grow into an experienced surgeon. As a result, the demand for the cataract surgeons is unmet, especially in remote regions. Additionally, considering physiological limitation by human brains, eyes, and hands, developing an automated surgery robot is necessary. Initially, we developed a deep learning-based evaluation system for cataract surgery. Deep surgery system, it could real-time monitoring and feedback during the surgical process, and its evaluation capability matches the expert level. In collaboration with the engineering team of SYSU, we established a robotic platform that can fit out human chambers and scale down motions. The robot system has the advantage of high precision localization, provides a 3-dimension view, and helps prevent hands trembling. That allows for both local and remote control. Thereafter, animal experiments were conducted to test the performance of the robot for the key procedures. The first attempt is incision construction, which is the initial step for cataract surgery. The picture below is the robot's work. It shows the stable, clear tuner incision within transparent corner. In another recent experiment, we tested the performance of the semi-automated robot for capsulolysis. Since a good capsulolysis is half done for a successful cataract surgery, the robot-made capsulolysis achieved comparable success rates compared with human beings, with better precision and reproducibility indexes. For the prognosis of cataracts, although we have consensus that the structural and functional state of the fundus plays a key role in the prediction of post-operative visual acuity, the fundus observation is commonly obstructed by the cloudy lens, especially for the advanced stage cases. The clinically applicable devices such as interferometer cannot achieve satisfaction accuracy in all types of cataracts. Inspired by the design of X-ray scanning, we proposed digital ray to penetrate lens and achieve better clarity in retinal images. It was developed using GAN frameworks based on pre- and post-operative image pairs. Fundus images generated by digital ray presented both improved quality and diagnostic accuracy for retinopathy such as AMD, DR, and retinal detachment. Furthermore, we developed a prediction model for post-operative BCVA based on generated fundus images by digital ray combined with the slit lamp images and clinical metadata. Pilot study results indicate that this method achieves more accurate prediction than traditional deep learning models, so as to provide alternative methods besides laser interferometry method. So far, we have applied the AI medical system in real-world primary care settings since 2018 and screened more than 10,000 citizens. It was proved that the digital screening patterns could increase the service capacity of eye doctors by more than 10 times. We further proposed the digital hierarchical screening patterns, which is commented on as an efficient and effective method. Last year, we conducted an economic evaluation and proved that the novel pattern was more cost-effective than traditional screening methods. It could avoid more blindness years, meanwhile saving more cost. In the end, I'd like to quote an ancient Chinese saying to express my heartfelt thanks to my team members and our invaluable partners from collaborating institutes. 志何止不以山海为远 The people with the same mission can gather and collaborate despite the long distance apart, or the diversity in academic backgrounds. Thank you all for your being here. Thanks.
Thank you. I think we'll not have a, because this was a recorded talk.
Good morning.
I request Simon to talk on retinal imaging. Can you put the slides?
This one.
Oh, we'll have the, Simon is not there, so we'll have the corneal imaging. Dr. Marcus Ang would be talking on
That one.
corneal imaging. Retinal imaging has
Yeah,
been
this
covered
one.
too.
Yeah, so last but not least, from the back of the eye to the front of the eye.
Yeah.
Right, good morning. Thanks very much for joining us at the APOIS Symposium. I hope you found it useful. We tried to give a broad overview of the future of imaging all the way from glaucoma to retina and finally in the anterior segment. And I thought I'll share a little bit of the work that we've done in endothelial imaging in the cornea and how we could apply new technologies or imaging techniques with AI for clinical use. These are my financial disclosures. So as you know, corneal endothelial disease is actually one of the leading indications for corneal transplantation, and in fact, endothelial keratoplasty is now the most commonly performed corneal transplant. And in fact, other less invasive techniques such as DSO are actually coming more popular, and so imaging of the corneal endothelium is very important. I think most of us here are familiar with corneal endothelial imaging. It's usually done by specular microscopy, and current gold standard is really just a central small area in the entire cornea as a representative or surrogate for the rest of the corneal endothelial health. And so obviously this is not good enough. Now recently there has been technologies which help us capture wide field or larger areas of the endothelium. There are various machines that do this, but I'm just going to demonstrate one which is basically something that I find quite useful in terms of usability and speed. So as you can see from that video, that took about a few seconds, and basically the technician can choose which are the best images. So I'm going to show how we can apply such a technique in our clinic and in various indications, but also how can we interpret it by using AI. So I've mentioned two main indications for imaging the corneal endothelium. One is in Fuchs dystrophy and one is in corneal transplantation. So in Fuchs dystrophy, what happens is really the pathophysiology is the degeneration of the endothelium, and of course we are familiar with guttae that appears in the cornea. And you know, the relationship between the peripheral endothelium and the central endothelium has actually been quite well studied, despite us only performing central endothelial imaging. So what we wanted to do is to look at prospectively in patients who had Fuchs dystrophy, and to look at the function of how these wide field imaging techniques perform. And of course, one thing that's been mentioned in the optic nerve imaging and the retina imaging is image quality, because without good image quality, you can't generate good application, and you can't use AI to actually diagnose it. And so you can see different phenotypes here: patients with good central or poor peripheral endothelium versus poor central and good peripheral endothelium. And what we really wanted to look at is, number one, do we get good image quality in both central and peripheral? And as you can see over here quickly, we were quite satisfied with that. And what we wanted to see is that whether central, which is what most people are doing in the world, actually correlates with peripheral. And so what we found is that if you use a combination of paracentral, that means within 4 to 5 millimeters, and then try and extrapolate that to the 8 millimeter zone, then you are able to use this wide field imaging with pretty good certainty. I mentioned about DSO, and a quick introduction of this technique. Basically what some corneal surgeons are doing now in Fuchs dystrophy is to strip a central 4 millimeters of the decimase and leaving behind the periphery, and using ROCK inhibitor as an eye drop is to stimulate migration of the endothelial imaging, endothelial cells into the center, and that actually helps to clear the cornea. However, selection of these patients require, again, good peripheral cell counts, because you're stripping off the center and you're leaving the periphery behind. So can we use these endothelial imaging to select appropriate patients? So what we did was, we basically did a study to look at whether the images from the specular were normal versus abnormal. And what we wanted to really achieve is to develop an AI that helps us identify patients quickly. So which are the patients which have good cells in the periphery versus good cells in the center. And here are the AUCs that we derived, and we published this recently to look at whether patients can be identified based on just the specular images automatically using AI. Last but not least, we wanted to look at Fuchs dystrophy and patients with Fuchs dystrophy going for cataract surgery. So cataract surgery, as already mentioned by Hao Tian, is one of the most common, or if not the most common, surgery performed in the world. And cornea decompensation in patients with poor endothelial cells is one of the most common side effects or complications after cataract surgery. So what we wanted really to do, again using imaging as well as AI, is to look at whether we can identify the cells, as well as the cell counts, as well as the quality of the cells in all the images we're doing. Now, when we perform these wide field imaging, one of the issues is that we're going to generate thousands of images. So when we're performing central endothelial specular, you have one image, maximum 2 or 3 images. But when you're doing repeated wide field, what we really need is intuitive user interface, or UI UX. So what we're trying to show here really is that with all these thousands of images, the AI is able now to create regional maps. So we can see patients before surgery, which are the patients which part of the endothelium has good endothelial cell counts, good morphology, as well as good hexagonality, versus the patients who are post-op, and which part of the endothelium gets affected most. And what we wanted to also show in our studies is to basically that we are able to detect both the cells as well as the quality of the cells better, especially in the presence of cornea and cornea thickness changes. For example, just after cataract surgery, there may be some cornea edema in the first post-op month, and basically are we able to pick up the endothelial cells better. Last but not least, can we apply these wide field imaging to endothelial keratoplasty? So as mentioned already briefly, DMAC, for example, is one of the most commonly performed cornea transplantation techniques performed in the world. And of course, what we really need is to be able to predict which patients do well, which DMACs last, and of course, endothelial cells and endothelial cell loss is closely linked with graft survival, and we know this from numerous studies. So what we wanted to do is, again, perform wide field imaging in patients with DMAC, and basically look at the image quality on all these patients after they had DMAC, both the central, paracentral, and peripheral, and look at the endothelial cell decline after surgery, and whether we can use both the paracentral and the peripheral to predict whether patients perform, whether these DMACs survive longer based on their cell counts, and potentially we can use these wide field imaging techniques to predict graft survival. So what we did was, over a period of 18 to 24 months, we actually found that eyes which had larger peripheral cell loss actually led to a higher risk for graft edema or poorer graft survival. So there again, the use of wide field imaging over central imaging. So I think the future of wide field imaging in endothelium, I hope I showed you some good concrete clinical examples, but I think the future is even more promising, because we now have various AI techniques. As I mentioned before, when you do multimodal imaging, whether you're doing glaucoma or retina and in cornea, what you're going to have is a lot of images. So where the AI comes in is really how you can shorten the time for analysis, interpret it for the clinicians, and then combine it with other kinds of imaging techniques. For example, here we're using UHR or ultra high resolution OCT to even look at the endothelial cells. And so then we can apply these to our clinic. And last but not least, I just wanted to show implementation and where we can implement these AI and imaging techniques, whether it's in primary care, whether it's cornea specialists, or even general ophthalmologists, and how the AI will link all these technologies or image analysis so that you can actually apply them in our patients. So I'd like to acknowledge my team in SERI and SNEC, especially my imaging team, and I thank you very much for your kind attention. So this is the last talk of the APOIS session. Do we have any questions or?
Any questions anybody has? Just one question. Do you feel I know that endothelium count, I'm a retinal surgeon, disclaimer. So I know endothelium count specular would be better, but do you feel any role of OCT? Because thickness indirectly gives measure of that. So if you can train OCT using the specular count, you can probably tell about the specular count by just a OCT.
Yeah, that's a great question. Unfortunately, just like in the macula, thickness doesn't always correlate with function, and in glaucoma as well. So I think we can't run away by using a single modality. I think in the end, just like glaucoma, we'll end up using multi-modality. Having said that, the UHR OCT image that I showed was a 3D reconstruction of multiple OCT images and then turning it on fast so you can actually see the endothelial cells. But that paper that we published uses a prototype OCT which takes a minute to do an OCT scan. So maybe not in the near future, but hopefully in the future.
Sir, I have one question.
Yes.
Again, disclaimer is I'm a retina surgeon, but just like in retina for the ultra wide field, we have the vortex bands as the the points beyond which it is ultra wide field. Similarly, in this cornea, can we define something like wide field or ultra wide field? Any marker beyond this diameter? This like that?
Yes. So I think the biggest challenge you look at all the papers that have been published on retina, on glaucoma, especially for image analysis and AI. I think the biggest challenge for cornea and anterior segment is the lack of registration. So all retinal images are centered on the disc, but for cornea, unfortunately, we don't have that point of reference. So I think that's going to be one of the biggest challenges. Yeah.
Thank you.
Great question.
I have a question.
Yes.
Marcus. So specular microscope and OCT and sometimes ultrasound, they only measure the structure. So like visual field test, is there any AI technique to measure the function of endothelium?
Yeah, so that's a great question as well. So like I said, the endothelial cell, of course, in its early or in its basic function is really cornea thickness, reducing cornea edema. But of course, we know that visual function in cornea is also affected by scarring, haze, and chronic thickness or dysfunction. So we do have imaging techniques in the cornea anterior segment, both OCT and tomography, to look at scatter, to look at density, to look at haze. And so I think, as mentioned before, I think it's going to be in the end sort of like a multimodal imaging kind of evaluation of the cornea in the future. Okay, if that's, we finished about 5 minutes early, but I think we're okay, yeah? Great. I would like to thank everyone for joining us in this session. I'd like to invite the speakers to join us in front for a photograph, if you guys are still around, and the chairs as well, of course. Is there a photographer here?